culturally, we have this very specific, very persistent image of pregnancy and motherhood. You know the one. It's the perpetually glowing mother.
Oh, yeah, the perfectly serene woman.
Right. She's serene, she's instantly bonded with her baby, and just like everything is naturally and effortlessly falling into place.
It is a beautifully curated picture, but I mean, it's entirely incomplete.
Mm.
And when you look at the actual clinical realities of pregnancy and the postpartum period, that cultural myth goes from being just unrealistic to, well, actively dangerous.
Yeah, it sets up this impossible standard, right?
Exactly. And it masks severe medical crises.
And breaking down that mask is really our mission for today. Welcome to today's deep dive. We're so glad you're here with us. We are taking a comprehensive look at perinatal mental health and substance use disorders.
It's a heavy topic, but
Yeah.
so crucial.
It really is. We are going to unpack how the medical field actually navigates this incredibly high-stakes intersection of maternal mental health, fetal safety, and the powerful stigma surrounding addiction.
So, okay, let's unpack this. Because treating severe perinatal mental health is a lot like trying to fix an airplane while it's in the air.
Oh, I like that analogy.
Right. You are managing two distinct lives simultaneously, and absolutely every intervention or, lack of intervention affects both the mother and the developing fetus or newborn.
That airplane analogy is essential to keep in mind because the stakes are literally a matter of life and death. To put this in clinical perspective, perinatal depression affects roughly 1 in 7 women.
1 in 7, that's huge.
It's massive. That makes it one of the most common medical complications across the entire spectrum of pregnancy and the postpartum period. And the starkest metric we have is mortality. Suicide is actually a leading cause of maternal death. Wow. I mean, that completely inverts our traditional understanding of maternal mortality. People typically assume the biggest risks of childbirth are, physical trauma.
They do. But more maternal deaths are caused by suicide than by hemorrhage or hypertensive disorders.
That is wild to think about.
It really is. I mean, we have these highly regimented, hypervigilant physical protocols for bleeding and blood pressure, right? But psychological symptoms are often dismissed, or they're hidden by the mother out of shame, or just myth attributed to, like, being tired.
Which brings us to the very first clinical hurdle, right? Accurate identification. Because let's be real, almost everyone is severely fatigued after having a baby.
Absolutely. The exhaustion is universal.
So how do clinicians actually separate the normal expected exhaustion of the postpartum period from a real clinical crisis?
So that diagnostic challenge starts with differentiating between what we call the baby blues and major postpartum depression, or PPD.
Okay, let's break those down.
Sure. So the baby blues are incredibly common. They affect like 50 to 70% of women. They involve mood swings, periods of crying, feeling overwhelmed, just general anxiety.
But it's temporary, right?
Exactly. The physiological distinction is that the woman's core functioning isn't impaired, and the symptoms resolve on their own within a few days to 2 weeks.
So it's a transient state, but PPD is a fundamentally different pathology.
Yes. PPD lasts longer than 2 weeks and is characterized by intense, pervasive sadness, severe insomnia, and frequently, and this is the really hard part, a profound feeling of detachment or a lack of love for the newborn.
Which just feeds right back into that shame we were talking about.
Absolutely. And the biological drivers behind this are massive.
Yeah.
During pregnancy, the placenta is like this endocrine powerhouse, right? It's producing enormous quantities of hormones.
Right. Yeah.
Once the placenta is delivered, the woman's body goes through this abrupt, massive withdrawal of estrogen and progesterone.
It's just a total crash.
A total crash. When you combine that sudden endocrine crash with rapid shifts in cortisol, thyroid hormones, extreme sleep deprivation, and potential nutritional deficits like low vitamin D or folate, the nervous system is completely destabilized.
And clinicians use specific screening tools to catch this destabilization, right? Like the EPDS, the Edinburgh Postnatal Depression Scale.
Yes, that's the standard one.
It's a 10-item questionnaire. And if a mother scores a 12 or higher, that triggers an immediate, deeper psychiatric assessment. But, reading through the sources, there is a glaring blind spot in perinatal care regarding who we screen.
What do you mean, partners?
Yes.
There you go.
We focus entirely on the mother, but paternal perinatal depression is a highly prevalent reality.
It really is. It affects 8 to 10% of men or partners during the pregnancy or in the first year postpartum.
8 to 10% is not a small number.
Not at all. I mean, partners experience the seismic shifts in household dynamics too, the severe sleep deprivation, the financial stresses. And that can manifest clinically as profound fatigue, anger, withdrawal, and even somatic physical symptoms.
Yet there isn't a routine screening scale designed specifically for fathers or non-birthing partners. They're largely just, well, invisible to the clinical safety net.
Which represents a critical oversight in public health. I mean, parental depression doesn't exist in a vacuum. Untreated maternal or paternal depression fundamentally alters the environment the infant develops in.
Because they're soaking all of that up.
Exactly. It's closely associated with long-term developmental impacts, including attachment insecurity, a higher risk of behavioral issues, and even lower infant IQ scores. The pathology of one parent ripples through the entire family system.
But wait, let me play devil's advocate for a second. How does a clinician practically differentiate between clinical depression and just being, heavily pregnant or newly postpartum? Wait, the diagnostic criteria for depression include fatigue, weight changes, and sleep disruption. But aren't those just the standard symptoms of being pregnant? How does a doctor actually tell the difference?
That is a great question, and you are identifying the exact reason these conditions are underdiagnosed. The physical overlap is immense.
Right, because you're tired and gaining weight anyway.
Exactly. So to bypass that confusion, clinicians are trained to look past the somatic symptoms and focus intensely on the psychological severity.
Ah, okay.
They evaluate whether the sleep disruptions are out of proportion to normal pregnancy discomfort. For instance, a mother who is entirely unable to sleep even when the newborn is resting and her own body is physically exhausted.
Like her brain just won't shut off.
Right. And most critically, they screen directly for suicidal ideation or a specific suicide plan. That psychological severity is the dividing line.
That makes a lot of sense. Because untreated PPD can escalate, we also have to examine what happens when those symptoms warp into terrifying, intrusive thoughts. Because the public frequently conflates two very different extremes of perinatal mental health, postpartum OCD and postpartum psychosis.
Right. People think they're the same thing.
They really do. They might share the theme of danger to the infant, but the internal experience of the mother and the required medical response are just worlds apart.
Let's delineate postpartum OCD first. So a mother with this condition experiences horrific, intrusive thoughts about harming her infant. But the defining clinical characteristic is that these thoughts are ego-dystonic.
Meaning they don't align with what she actually wants.
Exactly. They are entirely out of alignment with her actual desires. She is terrified and repulsed by her own thoughts. Consequently, she becomes hypervigilant against acting on them.
So she's basically guarding the baby from herself.
Precisely. She might proactively hide all the knives in the kitchen or refuse to bathe the baby out of this paralyzing fear that she might lose control.
She recognizes the thoughts are a malfunction.
Yes. Postpartum psychosis, conversely, is a psychiatric emergency where the mother actually loses touch with reality. It occurs in roughly 1 to 2 per 1,000 births, and it's heavily associated with bipolar disorder.
And in this case, the delusions are egocentric.
Right. In a psychotic state, the mother might genuinely believe the infant is possessed by an evil force or is destined to suffer a terrible fate.
Here's where it gets really interesting. Because she's in a delusional state, if auditory hallucinations command her to harm the child, she might actually comply, believing she is saving the baby.
Yes, she believes she's doing the right thing. The risk of infanticide or suicide is critical here. It is an acute medical crisis requiring immediate, intensive psychiatric intervention.
And these women require inpatient psychiatric care to stabilize. But ideally, this stabilization should happen in a mother-infant joint admission unit, right?
Ideally, yes.
Because if you completely sever the physical bond between mother and newborn during those critical early days, you disrupt fundamental attachment processes. But those specialized joint units are tragically rare. We can diagnose the crisis, but our healthcare infrastructure lacks the specialized facilities to treat it without causing secondary attachment trauma.
It's a huge gap. And what's fascinating here is we have to recognize the long-term predictive nature of this condition.
What do I mean?
Well, postpartum psychosis is rarely just an isolated reaction to childbirth. Data shows that more than 50% of women who experience first-onset postpartum psychosis will go on to develop a non-postpartum psychosis, like a bipolar manic episode, at some point later in their lives.
Wow. So the pregnancy was just the catalyst.
Exactly. The extreme physiological stress of the pregnancy simply acted as the trigger that unmasked an underlying, lifelong psychiatric vulnerability.
Because postpartum psychosis and severe depression present such acute dangers, clinicians are really cornered into using aggressive pharmacological
They
interventions.
have no choice.
Right. But introducing high-powered psychiatric medications into a pregnant or breastfeeding body raises a massive logistical problem. It brings us to the clinical tightrope. How do you use psychotropic drugs when every milligram crosses the placenta or enters the breast milk?
That tension dictates every decision in perinatal psychiatry. Currently, the FDA has not approved any general psychotropic medications specifically for use during pregnancy.
Not a single one.
Not a single general one. It is a perpetual risk-benefit analysis. The medical team has to weigh the known risks of the drug against the proven developmental and physical harm of leaving a severe depression or psychosis untreated.
It's like choosing between two storms.
That's exactly what it is.
Yeah.
And the chemical interactions can create sudden neurological crises out of seemingly harmless, over-the-counter medications.
Okay, give us an example.
Take SSRIs, which are standard treatments for depression. They work by keeping more of the neurotransmitter serotonin active in the brain's synapses. Well, if a pregnant woman on an SSRI takes dextromethorphan, which is the active ingredient in standard cough syrup, that combination causes a literal traffic jam of serotonin in the brain.
From cough syrup.
Yes, it triggers a rare condition called serotonin syndrome.
Okay.
The nervous system becomes completely overloaded. You see severe agitation, mental status changes, and hyperreflexia, which is when the body's reflexes become dangerously overactive and twitchy.
That perfectly illustrates the volatility of the pregnant system. And the protocols become even more rigid when administering mood stabilizers like lithium, right? Which are absolutely essential for preventing those manic and psychotic episodes we just outlined.
Lithium is notoriously tricky. It's cleared from the body through the kidneys. But during pregnancy, a woman's blood and fluid volume increases massively, which completely alters how her kidneys process the drug.
So you're constantly chasing the right dosage.
Constantly. The dosage has to be continually adjusted. And then, at the very onset of labor, the lithium must be abruptly stopped.
Because the physical act of labor causes intense, sudden fluid shifts.
Exactly. Between the start of contractions and the immediate postpartum period, the body undergoes a rapid redistribution of fluids. If the lithium isn't stopped, the sudden change in renal clearance could cause the concentration of lithium in the blood to spike violently.
Which means toxicity.
Severe lithium toxicity for both the mother and the newborn. The medication has to be halted, the physiological storm of birth navigated, and then carefully reinstated.
But, looking at the sources, there is a very recent, highly specific pharmacological breakthrough for postpartum depression that doesn't involve traditional SSRIs.
Yes, brexanolone, also known as Zulresso. Approved in 2019, it is the first drug developed and approved specifically for PPD.
It works differently, right?
Completely differently. Instead of targeting serotonin, it's a synthetic form of a neurosteroid derived from progesterone. It works by rapidly resetting the brain's GABA receptors, which effectively pulls the nervous system out of an intense stress response.
But the administration of it highlights just how severe PPD is. You don't just pick up a prescription bottle from the pharmacy. Because of the risk of profound sudden sedation, brexanolone requires a continuous 60-hour 5E infusion.
It's intense. It has to be administered in a certified healthcare facility with continuous pulse oximetry monitoring to ensure the mother's oxygen levels don't drop while she is sedated.
The logistics are just staggering. I mean, you have a mother suffering from debilitating depression, managing a brand new infant, and the treatment requires her to be tethered to an IV in a clinical setting for 2.5 days. It is an incredible biological mechanism, but it requires a massive support system to execute.
Which is exactly why perinatal care cannot rely on medication alone. It requires comprehensive social and clinical support.
Absolutely. Now, this delicate, highly monitored balancing act of prescribed medications naturally brings us to the management of illicit substances. Substance use disorder, or SUD, during pregnancy is an area of maternal health shrouded in intense stigma and public misunderstanding.
It really is. And, women account for roughly 30% of the addicted population in the United States.
30%.
Yeah. And the foundational rule in treating perinatal addiction is that visual or demographic assumptions are incredibly dangerous.
Because addiction crosses every single racial, socioeconomic, and geographic line. You can't just look at someone and know.
Which is why the current medical consensus dictates universal screening. Clinicians utilize validated, non-judgmental frameworks like the CRA-FFT tool or the 4Ps Plus.
The four Ps.
Right, the 4 Ps guide the clinician to ask about the parents, the partner, the past, and the pregnancy. It's a structured way to assess the patient's environment and history without immediately triggering defensiveness.
But we really have to address why that defensiveness exists in the first place, and it is largely driven by the legal reality. According to the text, in 24 states in the District of Columbia, substance use during pregnancy is legally defined as child abuse.
That's a huge barrier.
It is. In certain jurisdictions, women have been convicted of criminal child abuse based solely on prenatal substance use. Furthermore, if a hospital wants to conduct toxicologic testing on a mother or a newborn, whether they are testing maternal urine, hair follicles, or the newborn's first stool, known as meconium, they are legally required to obtain informed consent from the mother first.
The socio-legal implications here create a profound public health dilemma. If we connect this to the bigger picture, addiction is a disease heavily characterized by internal shame.
Right.
When you compound that shame with the very real threat of losing custody of their newborn to Child Protective Services or facing actual criminal prosecution, it builds an insurmountable barrier. It actively drives pregnant women with substance use disorders away from the healthcare system.
They're scared.
Exactly. They avoid vital prenatal care appointments because they are terrified of being tested and reported.
I want to pause here and ask you, the listener, to consider why this specific dynamic matters to you. You may not have personal ties to addiction or perinatal care, but understanding that addiction is a chronic, relapsing medical disease rooted in neurobiology rather than simply being a moral failing fundamentally dictates how our society functions. If our systems treat it purely as a criminal issue, we alienate the most vulnerable patients. Shifting that view to a medical framework changes how we fund community clinics, how we support high-risk maternal care, and ultimately it dictates the health outcomes of the next generation.
That's perfectly said. And when pregnant women with substance use disorders are supported enough to interact with the healthcare system, the actual medical protocols for treating them are highly counterintuitive.
Yeah, they contradict almost everything the general public assumes about addiction treatment.
They really do.
Right, the popular narrative of getting clean usually involves sudden detoxification, locking the doors and sweating out the withdrawal. But doing that to a pregnant woman addicted to opioids is entirely against the standard of care.
Absolutely. Sudden medical withdrawal from opioids during pregnancy is strongly discouraged
Why is that?
because the fetus relies entirely on the maternal blood supply. The extreme physiological stress of a sudden maternal withdrawal triggers massive instability in the placenta. It creates a very high risk of fetal distress, and in severe cases, fetal demise.
Oh, wow.
Furthermore, the statistical risk of the mother relapsing into illicit use after a sudden detox is dangerously high.
So to avoid that crash, the gold standard of care is opioid agonist therapy. They transition the mother from illicit street drugs onto a highly regulated, prescribed, and monitored dose of medications like methadone or buprenorphine.
Exactly. You could think of methadone or buprenorphine as a biological shock absorber. It binds to the opioid receptors in the brain, preventing the violent physiological crashes of withdrawal, but it doesn't produce the chaotic highs of illicit opioids.
It just levels everything out.
Right. It stabilizes the maternal environment, stops the cycle of seeking illicit drugs, and keeps the mother consistently engaged with her prenatal care team.
But because it crosses the placenta, the baby is still physically dependent on the medication at birth.
Yes, that's true. The newborn will likely experience neonatal abstinence syndrome, or NAS. They may exhibit symptoms like tremors, excessive crying, sleep issues, and feeding difficulties as the drug leaves their system.
Which sounds scary.
It does, but the clinical data is definitive. A monitored steady dose of prescribed buprenorphine that results in manageable NAS is vastly safer for the developing fetus than the chaotic, dangerous cycle of illicit opioid highs and sudden withdrawals.
Which brings us to perhaps the most fascinating physiological mechanism in the treatment of SUD. It involves breastfeeding. The medical guidelines are unambiguous. Breastfeeding is strictly contraindicated, meaning a mother should absolutely not do it if she is actively using methamphetamines, alcohol, or cocaine.
The neurological risks to the infant are just far too high.
Right. But if a mother is stable and participating in her prescribed methadone or buprenorphine treatment program, clinicians actively encourage her to breastfeed. Wait, let me get this straight. The baby might be going through withdrawal, and the prescribed treatment is breast milk that actually contains traces of the opioid.
It sounds entirely paradoxical at first glance, I know. The infant is actively going through withdrawal, and the treatment is to feed them milk with that exact same drug.
But the biological elegance of it is incredible. The mother's body naturally titrates the dose.
Exactly. When a mother on methadone or buprenorphine breastfeeds, tiny, heavily filtered amounts of the medication pass through the breast milk. It acts as a gentle, natural taper for the infant.
Oh, wow.
Clinical studies prove this actively decreases the severity of the infant's neonatal abstinence syndrome symptoms. It significantly reduces the baby's need for aggressive pharmacological interventions in the NICU, and it drastically shortens the infant's overall hospital stay.
That is amazing. It is treating the infant's withdrawal using the mother's own biology as the filtration system.
And it's a holistic medical intervention. Beyond the pharmacology, the physical act of breastfeeding promotes deep maternal-infant bonding. It empowers the mother, reinforcing her identity and capability as a caregiver.
Which has to be huge for her recovery.
Huge. It provides incredibly strong psychological motivation to maintain her sobriety.
So, what does this all mean for us? We have covered a massive amount of clinical ground today. We started by peeling back the myth of the perfectly glowing pregnancy to identify the hidden, severe realities of major postpartum depression and the extreme psychiatric emergencies of postpartum psychosis.
We really went through it.
We did. We explored the incredibly complex pharmacology of managing psychotropic drugs during pregnancy, understanding how a simple cough syrup can trigger a serotonin traffic jam, and how the fluid shifts of labor necessitate perfect timing for lithium. And finally, we dismantled the stigma surrounding maternal substance use disorder, exploring how methadone and breast milk work together as a biological shock absorber for a recovering newborn.
The overarching theme embedded in all of these medical realities is the absolute necessity of compassionate, evidence-based care.
Compassion is key.
Always. Whether a mother is battling an acute psychotic episode or navigating a chronic substance addiction, the most effective medical intervention is a supportive interprofessional healthcare team that operates with immense patience and zero judgment.
I want to leave you with a final thought to mull over, building directly on the legal paradox we discussed earlier. The source material notes that toxicologic testing for drugs requires informed consent, but also points out that in many states, positive results must be reported as child abuse. It raises a profound question. If our legal framework threatens criminal prosecution for a medical disease, are we actually jeopardizing the safety of the very infants we are trying to protect by terrifying mothers into hiding from the healthcare system altogether? Something for you to think about?
It forces us to ask whether our desire for punitive accountability is overriding our responsibility to provide genuine medical care.
It really does, because at the end of the day, managing severe perinatal mental health and addiction really is like trying to repair that airplane mid-flight. You cannot just ground the plane and stop the pregnancy or pause the postpartum period. You have to keep it flying, carefully balancing every single chemical, psychological, and social adjustment so that both the mother and the child can land safely. Thanks for taking this deep dive with us. We'll catch you next time.